All right, today we are cracking the code on something absolutely essential in healthcare: electrolyte imbalances. And look, these aren't just some abstract chemicals on a lab report. They are literally the messengers that keep our bodies firing on all cylinders. So let's just dive right in.
So, let me ask you this. What is it that makes sure your heart keeps beating, every single nerve impulse fires just right, and every thought even forms in your brain? Well, it all comes down to this incredibly delicate balance of minerals. And when that balance gets thrown off, things can get serious, fast. That's exactly what we're going to unpack today.
So, at its very core, what is an electrolyte imbalance? It's just a disruption of these essential electrically charged minerals. We're talking about sodium, potassium, calcium, the big players. They are absolutely fundamental for everything, from your muscles contracting to just keeping your body properly hydrated. When their levels go too high or too low, the whole system really starts to feel it. Okay, so here's our game plan. We're going to start with sodium, which is all about balancing our fluids. Then we'll hit potassium, the one that's so crucial for the heart. After that, we'll group calcium and magnesium together. Think of them as the great stabilizers. And finally, we'll wrap up with a quick look at phosphate and then tie it all together with the acid-base balance.
First up is sodium. The easiest way to get your head around sodium is to just think of it as the body's water magnet. It's a simple rule. Wherever sodium goes, water is sure to follow. And that one little principle is the key to understanding both of its major imbalances.
So here we've got two sides of the exact same coin. On the left, you see hyponatremia. That's too little sodium. This can happen if someone drinks way too much water or from conditions like SIADH, where the body just holds onto water, which dilutes all the sodium. This makes cells, especially brain cells, swell up, leading to those scary neurological signs like confusion and even seizures. And on the right, the total opposite: hypernatremia, too much sodium, usually from straight-up dehydration. The body's just parched, causing that intense thirst and restlessness. And because the problems are opposites, the treatments are direct opposites too, which, makes a lot of sense. For low sodium, we do the logical thing. We restrict water intake and, very carefully, might give a concentrated salt solution. But for high sodium, the goal is rehydration. So we give IV fluids that are less concentrated than the blood to help dilute all that extra sodium. All right, next up, potassium. If sodium is the water magnet, I want you to think of potassium as the heart's personal drummer. It's responsible for the electrical rhythm that keeps the heart beating steadily. And let me tell you, even tiny shifts in potassium levels can be life-threatening. And on this slide, you can really see how high the stakes are. With low potassium or hypokalemia, the heart muscle can get really irritable, which can lead to dangerous arrhythmias. The patient might feel weak, tired, and get muscle cramps. But with high potassium, hyperkalemia, the danger is even more immediate. It can cause very specific changes on an ECG and, in the worst-case scenario, full-on cardiac arrest. And notice that cause on the right, renal failure. We're going to see that one again. So what do we do? Well, the number one priority for both is cardiac monitoring. You have to watch that heart. For low potassium, we replace it. And this is a huge safety alert. You never ever give potassium as an IV push. It can literally stop the heart. For high potassium, we have to move fast to protect the heart, usually with calcium gluconate, and then we give things like insulin and glucose to force that extra potassium back into the cells. Okay, moving on to our dynamic duo, calcium and magnesium. I like to call them the stabilizers because their main job is to keep our nerves and muscles calm. They prevent everything from getting too twitchy or, on the flip side, too sluggish. Now, with low calcium, the nervous system gets way too excited. This can lead to something called tetany, where muscles contract involuntarily. And you might see classic signs like Schaafstedt sign, where you tap the facial nerve and the face twitches. It can even lead to seizures. But on the other hand, high calcium acts like a sedative. It causes lethargy, constipation, and puts the patient at a huge risk for painful kidney stones. The actions we take are a direct response to these problems. For low calcium, safety is everything. We put them on seizure precautions and, of course, replace the calcium. For high calcium, we're pushing fluids like crazy to try and prevent those kidney stones from forming, and we get the patient moving. Activity actually helps the body put calcium back where it belongs, in the bones. Magnesium follows a really similar pattern. Low magnesium, which we often see with things like alcoholism and malnutrition, creates an overexcited state. We're talking tremors and hyperactive reflexes. But high magnesium, commonly caused by, you guessed it, renal failure, leads to a state of severe depression, low blood pressure, a slow heart rate, and even respiratory depression. It's serious stuff. So for treatment, we give IV magnesium, slowly, for a deficiency. But for an excess, and this is a really cool one to remember, we have an antidote. Calcium gluconate acts as an antagonist to magnesium, and it can quickly reverse those life-threatening depressive effects. That is a super important piece of information to file away. All right, let's bring this all home with the final pieces of our puzzle. We'll touch on phosphate really quickly before we zoom out to the big picture system that connects everything: acid-base balance. Now, phosphate often has this inverse kind of seesaw relationship with calcium. So when one is high, the other tends to be low. And what's a key cause of high phosphate? Renal failure yet again. The treatment for this is actually pretty clever. We give patients something called phosphate binders with their meals. They basically act like magnets, grabbing onto the phosphate from food and stopping it from ever being absorbed into the body.
Okay, so have you been noticing a pattern here? This slide calls it out directly. Whenever you see a patient with a hyper state, too much potassium, too much magnesium, too much phosphate, your brain should immediately think about renal failure. The kidneys are our master filters, right? And when they aren't working, all these electrolytes just build up to dangerous levels. It's a huge clue.
Now let's zoom out. All of these electrolytes, all these players, are operating within the body's pH environment. And the main way we measure and understand that environment is by interpreting something called arterial blood gases, or ABGs. These are the normal values, and honestly, you've just got to memorize them. They represent that perfect balance the body is always striving for. For what we're talking about today, we're really going to focus on those top three: the pH, the PaCO2, which is our respiratory component, and the HCO3, or bicarb, which is our metabolic component. And here's the golden rule. The absolute first number you look at every single time is the pH. Is it below 7.35? The body's in acidosis. Is it above 7.45? The body's in alkalosis. That one number instantly tells you the patient's overall state. Start there, always. Look, interpreting ABGs doesn't have to be this big, scary thing. It's really just a simple 4-step recipe. First, like we said, check the pH, acidosis or alkalosis. Second, look at the PaCO2. That's our respiratory gas. Third, look at the HCO3, our metabolic buffer. And the final step is just putting it all together to see which system is causing the problem and if the other system is trying to help out or compensate. And here is a fantastic little trick to remember how to do that. If the pH and the PaCO2 are moving in opposite directions, think of a seesaw, the problem is respiratory. But if the pH and the HCO3 are moving in the same direction, like they're riding an elevator together, the problem is metabolic. This simple rule, it's gonna be your best friend for decoding ABGs fast. So, let's wrap all this up with the most important takeaways. First, remember that the hypo and hyper states of an electrolyte often look like polar opposites. Second, constant patient monitoring, especially of the heart and the brain, is absolutely vital. Third, don't forget that renal failure is a major, major culprit in so many of those hyper states. And finally, remember that interpreting ABGs isn't some kind of magic. It's just a logical, step-by-step process. Wow, we have covered a lot of ground today. From sodium in water to the heart's rhythm, all the way to the body's pH. You've seen the signs, you've learned the life-saving actions. So as you move forward, I want you to think about this. Which one of these delicate imbalances are you going to be watching for most closely? It's a great question to reflect on. Thanks so much for tuning in.